So just a quick overview of what we're going to be doing today. So Gillian and I will tell you just a little bit about us and our backgrounds, so you know where we're coming from. And then we'll talk a little bit about what we mean by engagement, because it's actually a pretty broad term and a lot of people mean it in different ways. So we'll kind of get into some of that. We'll talk about why it's important to your app. I think Vivek helped us set up that in that way. So that was helpful intro there too. We'll go through some techniques that we've used in our own work, as well as other examples that we've seen both in research projects as well as commercial projects for engaging people in mHealth design. We'll talk about some of the ethics around engagement, and then we'll talk a little bit about how to evaluate for engagement. So as I foreshadowed with Vivek, we have two ways that we're going to engage you. So interactivity is one of the key ways of making things engaging. So to engage you all this morning, I know it's early. I know you've had a lot of work ahead of you. You have still some of it to go. So we're going to do some things there. So we'll have two techniques that we'll use. One is the Zoom chat. So hopefully you'll have that open and handy. We'll have some questions and you can kind of enter in things with the Zoom chat, and then we'll put you in breakout rooms for a couple. We'll put you in your team breakout rooms to kind of specifically discuss how some of the things that we're talking about are applying to your projects that you're working on, which I'm really excited to hear about. So if you see either one of these two symbols, it's your it's your sign that we're going to ask you to engage with us in the presentation. Okay, so just a little bit about me. I'm a professor, also department chair of a small and unique department called Human-Centered Design and Engineering. So I'm the College of Engineering and the University of Washington, and we're a really interdisciplinary mix of people. So people with computer science backgrounds like me, combined with social scientists, combined with designers, and we're all kind of thrown into one department and to see how we get along. And so it's been really great and exciting experience. So my research primarily focuses on computing interventions for health, education, and families. And so you've done everything from, working with individuals tracking their sleep to tracking children's development, thinking around supporting nutrition and identifying food triggers for things like irritable bowel syndrome, smoking cessation, all sorts of different things and projects I've worked on. As I mentioned, I have a background in computer science from Georgia Tech, and my research field is human-computer interaction. And fun fact, Gillian and I are actually lab mates at Georgia Tech. She was 1 year ahead of me in the same lab, so I learned everything I know from her. Also, I have two kids that are my inspiration. And I love things like Pokemon Go, and I learned so much about things like these different types of apps and how they engage you, and I love to apply them to different types of things that we design as well too. Gillian, go for it.
Okay. Julie definitely did not learn everything she knows from me, but it is true that we both did our PhDs at Georgia Tech in computer science and had a very fun time there. So long-lasting friendships. I am a professor at UC-Irvine. My primary place is in a wacky department like the one Julie described that she chairs here at UCI. It's called informatics. It's also a mix of social scientists and designers and humanists and computer scientists and so on. But I also hold courtesy appointments in a bunch of places all around campus because the research that I work on is largely about how do we design in cooperation with the communities that we're trying to impact. And those tend to be in education and healthcare settings for me and the work that I do. Occasionally, because I'm very student-led in the research that I do, it goes a little bit out of bound, which is how I have an Alzheimer's project at the moment. But I normally work at the much younger end of the spectrum there. My day job these days is taking care of the grad students on campus. So I'm the dean of the grad division, which means I'm in charge of everyone who's not an MD or a JD. So that's what I spend most of my days doing. When I think about engagement these days, it's about how to engage our grad students in their curriculum and how to engage faculty in mentoring them. I also have a couple of kids like Julie and one dog who may make an appearance. She has a new toy, which results in her coming and dropping it on my lap and crying quite a bit. So you may see that in the next couple of hours. And I always like to include one thing that's not about things. I did not spend 11 hours playing Pokemon Go this weekend like certain people, but I do really like to volunteer and support the arts because I have zero artistic ability. So this is my way of engaging with that part of myself. Okay, so now you know a little bit about us. We've already used the word engage about 100 times in this discussion, and I was struck yesterday. So those of you that are in team 2, apologies, you're going to get some revamp of yesterday's conversation. I added this slide because of our conversation in our team yesterday, where I had this realization about halfway through our discussion that we were using engagement to mean all kinds of different things and using it in really different ways. And so I was talking to Julie about this, and I was like, you know, everybody's using engagement in all these different ways. I think we might need to open with a little bit, just here's some citations that you can go and read. And as I understand it, you got Susan Murphy's paper yesterday. So that citation is in here, and it sort of gives you a nice overview of the way that different fields think about engagement. The two that I want to focus on for today is sort of medicine and health sciences broadly, and then information science, human computer action design, the kind of spaces that Julie and I are from. So in medicine, I like this definition from Higgins et al., the desire and capability to actively choose to participate in care, and then goes on to sort of talk about the uniqueness and the appropriateness and personalization and so on, but really actively participating in care. And the reason I think that's important to bring up is because in design, and we're going to talk about this, we'll have a little ethics discussion in a little bit, but a lot of what we do in computing, for better or for worse, is not about allowing people to actively choose to participate. It's a lot about like, how do we suck you into our product, whether you want to be there or not? And so some of the techniques that we'll talk about today come from that kind of direction. But when we talk about health activation, it's not sort of necessarily about coercing or manipulating people into things, but about them making the choices to actively participate. But you still see sort of sub things that are very similar. So in information science, there's this nice list that O'Brien and Toms came up with: challenge, positive affect, and durability, and so on. And games, I think for me, are sort of the best place to see all this working really well. If you want to see how people bring people into a system and have them interact. And you'll see it's not that different from notions of personalization, access, commitment, and so on that you see in the medicine side. So the slide 7, I'm not going to walk you through this in detail, but this is from Susan Murphy's paper that you may have seen yesterday. And I think this table is lovely. And I did not know about it until Team 2's discussion yesterday. So thanks, Team 2. But this talks about all of these other constructs. So sometimes when people talk about engagement, you'll hear somebody say, well, they're engaged if they're logging into the app every day. Maybe, but that's really a measure of adherence. So that's a sort of similar but important concept, or participation or other things. So I just want to kind of lay this out for you, as there's lots of ways to do this. We're going to talk about some of them, but make sure that when you're talking in your teams or for years into your future projects, this is one of those cases where, you know, there's sort of joke about British people and Americans, like two nations separated by the same language. This is a lot what we are when we talk about in health sciences, in psych, in design, in these different places. We are all these groups using words like engagement, and we may think we know for sure what it means, and it may mean something radically different. So just kind of want to flag that for you. And as I say, there's some references on slide 6 that you can go back to. But we thought it would be good, and we can look at slide 8 quickly, to just say, you know, why does it matter? Given that it could be all these things, you know, whatever definition of engagement you are using and thinking about, why do you think it matters? And for some of you, this might really make sense to talk about your mHTI projects, but for some of you, it might be research or something else, or even your own, you know, home lives or professional lives or whatever. Don't restrict yourselves, but go ahead and start dropping some stuff into the chat to share with folks about why you think patient engagement really matters and makes a difference. And if you've already got the slides open, do not sneak ahead to slide 9 and see what we said. You can type in your own.
It doesn't have to be well thought out. This could just be whatever comes on. Okay, great, Agatha.
There we are. Okay.
Okay, there we go. Now they're all coming all at once.
Oh my goodness. Okay. So researchers have blind spots. Great point, Jess. We don't necessarily see what's going on. Agatha pulling out the neuroscience words, your prefrontal cortex needs to be involved. Fantastic. Absolutely the case, Carrie, that if we're not engaged, we're not necessarily absorbing what's coming. And that's one thing you'll see. Education uses the term engagement quite a bit as well. And you'll see there they talk about learner engagement and those kinds of things. Heather, you're so optimistic. That's the whole point of mHealth. I love it. I wish that was true. We're gonna say yes. Let's see, I'm struggling to read everything. There's so many good points here. Empowering, it can be empowering. So that's a question, Laura, I think to think about and discuss throughout the topic today. Is engagement empowering? When is it, and when might it not be? And you can think about some of the kinds of tech that you might use in your life that
I really like Carrie's point around engagement and dosing. Yeah, the concept of dosing in the medical community, and engagement is sort of like the digital equivalent of that we're still trying to understand and learn. I think that's a really, really great point and a really interesting point that, yeah, engagement is certainly something that is really emerging in our understanding, as kind of Gillian pointed out, and that there's sort of disagreement on what that even means.
I love Ethan and Damon have a combo set of comments that must come in about the same time about sort of habits for improvement and long-term engagement. And that's where we really talk about healthcare engagement.
Yeah. And making sure that it's, yeah, I think, is it Tamilawu or Tamilua? That's a really great point about making sure that things are useful. And that making sure that it's something that patients actually want to be doing, or patients, you find that it's helpful for their lives. It's sort of just something that's been prescribed to them by a doctor, or if it's something that, you know, they're just being, you know, maybe a family member's pressuring them to do it, then that's not really going to be engaging, and it's not going to be good for their health either. So making sure they understand that it's something that they really want and can use and can be useful in their lives.
I see a lot of words about sort of self-management, self-efficacy, empowerment, generalization, absolutely. Sort of translation from certain aspects of your life into another. Other thoughts that folks have? This is a great list.
Yeah. Yeah, you do better than my graduate students when I do this in class. So sometimes I have to wait awkwardly in silence for them to start putting things in the chat, but you're doing great. Sustainability is another great one.
So the list we put together on slide 9 is just sort of what we see backed up by the research literature over and over again. And I think everything that you all said is true and interesting. We should think about it. This is sort of in some ways, these are meta points of a lot of the things that you said. So there seems to be lots of evidence that patient engagement can improve health outcomes, satisfaction, and so on, reduce costs. That to some degree gets into the sustainability and scalability issues that you all brought up, and so on. From the tech side of the world, why do people care about engagement? It's in some ways very sort of, financial incentives and economical, right? Keep the customers coming back. Why do we care that you're engaged with your iPhone? Well, because then you're going to buy the new one when it comes out. And that in turn makes your shareholders and investors very happy. And I'm not so cynical as to think that it's all capitalism, but a lot of the design kind of techniques that we think about come from a world of driving customer growth and customer retention in the digital space. And I just want to bring that up because I think the mHealth world is filled with people who have very similar goals and are working towards very similar kinds of sets of concerns and long-term outcomes that we want. At the base of a lot of our techniques, there's some differentiation. When you think about an entire field that was built on growth and scale and bringing in customers versus an entire field that was built on a very specific sort of set of outcomes, you can have really synergistic moments and you can have moments of conflict. And so thinking about why does engagement matter from these two different perspectives, I think will be useful to you in going through your projects. All right, so with that, I'm going to slip it to Julie to start talking about techniques for engagement.
I lost my Zoom window keeps moving around all the mute buttons, so I have to keep hunting for it. Great. So we're going to go back to the chat again. So this time we want to hear about, we kind of talk about like why it's important, but now we want to know how you've seen it done. So, there are apps that you've used or mHealth interventions you've worked on or seen of specific kind of techniques you've seen for engaging people. So obvious ones are things like reminders, right? The little pop-up notifications that come up on your screen. But what are some other things that you've seen or ways that you've seen that the different mHealth tools can engage people? Yep, gaming, gamification, journaling, yep. Using behavioral economics. Yeah, behavioral economics is kind of a whole slew of kind of things, but using that component there. Animations, yeah, the user experience, sort of just making it really kind of really fun or playful can be part of that. Using coaching, Duolingo, yep. Using things like in Duolingo has things like streaks, so you have to kind of get these like, we get these bonuses for keeping up a streak for overtime or earning badges for accomplishments and things. Getting rewards, yeah, social, getting feedback from peers, or getting kind of that, those likes or kind of messages or things from peers. Let's see, sending reminders to their peers. Oh yeah, peer support, that can be another one. Self-monitoring, communication, yep, peers as well, and gamification, and personalization and adaptation. Yeah, so making it tailored specifically kind of to their needs or to their kind of ways of engaging. And I think that's one key point as well too, is that different people are going to be motivated by different things. So I love games. I already admitted that to you. I did spend 11 hours on Sunday walking 11 miles. It was Pokemon Go Fest in Seattle. So I did, but it was like all in service of finding kind of fun things. And so it worked for me. That does not work at all for other people. My husband hates games and he's like, what are you doing? Why would you do this? So that personalization or adaptation for different people and different needs can be something that's important. And that's something that mHealth has the power to do, right? It's really hard to customize a paper-based intervention in certain ways, right? That would be different, or even like a clinical-based intervention where an mHealth intervention can be customized. But as you may have heard from some of your others, when you do these adaptive interventions, it makes things messy, right? It's not this kind of clean, randomized control trial that you can do between those things. So I just want to highlight that as well too. Okay, let's see. Oh, there's other things that came up while I was talking there. So easy, attractive, social, and timely. Heather, that's a good one. Is that, I haven't heard that one before, EAST. That one's a good acronym.
That's a behavioral economics framework.
Oh, great. Excellent. I'll have to add that to our repertoire. Great. So as Gillian alluded to, some of this comes from the fields of things like persuasive technologies, one of the classic fields of using technology. So BJ Fogg at Stanford is one of the folks who sort of started along using things from principles from psychology and behavioral economics to try and engage people in here. So this is sort of his classic model around, there's this framework from motivation to ability. And if you have things like prompts to take action, if they're high motivation, then they have low ability, it's going to be better. But if they have low motivation and low ability, you're going to have to do a lot more prompting to get them to do things. If they have high ability, it's something that's easy to do. They have low motivation, then that's okay too. And ideally, you're sort of going to be doing things that are improving people's motivations as well as making it easier for them to do. And the more you kind of push things out towards those edges, the easier it's going to be to get someone to take an action. And so a lot of those, from the tech industry, a lot of people took this class at Stanford and started to apply these things into the design of tech tools. So you see a lot of these things like streaks and notifications and kind of breaking things into small chunks and little goals and things have sort of been developed along from some of this classic literature. Gillian already mentioned this as well too, but Susan Murphy, this article just came out, so I just want to throw this in here as well too. There's sort of another model that's sort of building in context and cognitive energy and physical and emotional energy and sort of building through starting with a stimulus and having attention over time. I literally just saw this paper yesterday, so I'm probably not going to explain it as well as Susan would. But I just want to throw this in here as another great way. And it's the fact that this field is constantly emerging and coming up with new techniques and tools. So again, we really want to recommend that paper for you all to read through. And this is one thing that I've found that be helpful and kind of as a teaching tool. So Johnson & Johnson has this kind of 7-point principles for engagement and patient health. And so what we're going to do for the rest of this smaller section is to kind of go through each of these items on Johnson & Johnson's patient engagement and kind of give some techniques and examples that kind of fall into each of those things. So there's kind of three main things. So ownership, this is something I want to do, making me have ownership of something, or maybe around autonomy, the principles of autonomy, connecting to me. So communicating my language and supporting my supporters. And then the third one is confidence. So building up their confidence and what they can do. I'm going to go through each of these 7 items and give some examples about either things that Gillian and I have worked on or other things we've seen in the research or commercial space. Okay, so starting off in the purple section was mapping my path. So making it really clear where they are in the process. So you're just using some clear visual signals of where you are and what's left to do. So things seem really daunting if you're starting a new intervention or starting things and you have no idea where you're going or how far you are along. Imagine getting a grant and sort of like, okay, we've got 5 years and we don't know how we're going to get there and how overwhelming that would be. But if you see that nice little chart that has like, okay, year 1, we're going to do these things, and year 2, we're going to do these things, and you're kind of moving things along. So you have some classic kind of what they call design patterns in the design industry, or things like shopping cart. You kind of see what they call them breadcrumbs. And so, they're sort of like, okay, there's 4 steps to go through this checkout process, and you're currently on step 2, billing. It's so much nicer to know, like, is this the part where I click the button and it charges my shopping cart, or is there one more step? And so you can imagine that it's really nice to see when you have those sort of breadcrumbs that sort of walk you through where you are in the process. And so as an example, the bottom corner has, this is the app I mentioned where we help people design little mini self-experiments to help them identify their food triggers for IBS. And so we were randomizing them to either, on some days they would have lactose with their breakfast, and some days they would have lactose-free version of it. And so it would be a 12, or I think in this case, it was a 12-day experiment. And so we kind of gave them a calendar at the top to show them where they were in it. And so the light blue was the avoid lactose day, and the dark blue was to have lactose day, and then they would track their symptoms each day. And so it would allow them to kind of show where they were in the process and how far they had to go. And so when you have an end goal or have an end state in sight, then it's a lot more easy to stick with it till the end than if you think it's sort of ill-defined and not sure where you're going from there. So the next step is placing triggers in my pathway to turn effort into habit. And so I really like this one as a way of helping make things really easy. So if you think about that BJ Fogg model, that's like easy to do, makes it easier, even if they're not well or highly motivated. And so one really clever example from, this wasn't someone at my university, but I wasn't involved in this, was building logging into people's unlock actions on their screen. And so, this, you can see over here that the unlock screen, this is on Android, instead of just like sliding to unlock, this is before face things would come up and unlock for you, but you would actually take the a little smiley face, and then it would actually come up with a little 5-point scale about like how you're feeling about it, like a mood logging. And so with just the choose quick swipes of your phone, you unlock your screen by actually logging how you're feeling. And so I think they also did a way of doing it with the mood versus, positive versus negative, the circumplex model of moods. So you can kind of just unlock it to tap on the screen with 1 or 2 clicks. And so you can imagine if you're trying to do something like experience sampling throughout the day, how many people unlock their phone like 150 times a day, right? And so rather than sending them a text message, waiting for them to respond and like kind of putting them in there, like you could get so much more logs just through that unlock screen there. I do love text messages, by the way. So not that's actually a really great way of engaging people. It's really about going to where they are as opposed to relying to come to you. So the App Store is filled with thousands and thousands of apps that people download and never open because it expects them to come to it. You really want to come to where they are to engage them. And every phone has text messaging. And even though we have fancy phones with smart apps and we could do all these cool things with it, text messaging can be really, really, really effective. In fact, I had one project that we did where we had sort of this nicely designed web portal you go in. It was like really rich and engaging. And like halfway through, we introduced text messaging as a way to kind of engage them, and engagement shot way up more so with the text messaging than it ever did with the app, because we were going to where they were as opposed to expecting them to come to us. Okay, next up is addressing the smallest action that matters, and then you using that to unlock chain reaction for success. And so this is really about kind of thinking through these proximal outcomes of what is it that as opposed to like targeting something big like losing weight or even improving physical activities, trying to think through sort of what is the smallest actionable thing that will get me towards that goal in a way that feels a lot more doable. And so, when someone has sort of made a decision to make a behavior change or improve some aspects of their health, it seems really daunting. And so it's like, gosh, maybe my goal is to, eat healthier, exercise like 5 times a week, right? And you could just know how big, in the beginning, they might be really motivated, but then they'll burn out, right? And so, but if you think about like, well, let's start with a small goal, like, 4,000 steps per day and work our way up from there, then that seems a lot more doable. So kind of thinking through that closest action that you can do and building up from there. And those really small successes will help them build there. And that's part of some of the things around gamification too, where you're sort of starting with these small, easy things and they get this positive feeling of accomplishing something and then they want to do more, right? And so that's really kind of what that is. And I think, Pedja Kazanya and Eric Heckler have been really great about sort of helping people think through causal pathways and sort of you thinking through, what's your ultimate goal and how can you sort of break that down in sort of like the tightest little piece of that and think through that as your intervention. So really great work there to work on. Next is build on what I'm doing right to nurture good behavior. And so, I think there's this temptation to have us, say you're trying to stop something like negative, like, drinking or smoking or things like that. There's this temptation to have you log things like how many drinks did I have and how many cigarettes did I smoke? But logging a negative thing is really not a great feeling for people. And is there a way you can flip that around to the positive? And so I worked on 2 projects related to this. So the first one was a project called Baby Steps, where we were helping parents track their kids' development and help them identify if they needed to get connected to early intervention services. And a lot of the campaigns are around like looking for these red flags. Does your child not make eye contact? Does your child not respond to the sound of their name? And that was, we interviewed families and they were really scared to be looking for these things, right? It's hard to sort of look at your child and look for the negative things. So we flipped that around and did more strength-based assessments. And so having them track the things that they can do as opposed to tracking the things that they can't do. And red flags can be important too. But I think it was much more accessible and more positive for people to track the positive things that they were doing as opposed to the negative things. And likewise with smoking cessation, rather than saying, oh, you know what, I smoked a cigarette today, we actually had them track the times that they wanted to smoke and they didn't. And so there's the resistance to that urge that they had to smoke. And so that was a positive thing. And so we had them actually just track the urges that they had to smoke, but didn't. And that was really effective at getting them to do that much more so than actually just logging, I had 5 cigarettes today or I had 10 cigarettes today. It's like, how many times did I want to smoke, but I resisted that urge? So think for the positive things you can do as opposed to the negative. Next up, delivering the right information at the right time. So this is around like kind of just in time, right? So if you deliver information to people and they're not in a place to act on it, then they're going to forget it. They're not going to engage it. But if it's sort of in the moment of decision making, that can be a really opportune time. So, one of my favorite classic examples is sort of, when people have to make the decision to take the escalator or take the stairs, right? That's the moment of decision. You have the escalator on the right and you have the stairs on the left. And that's the moment to kind of intervene, not, a public health announcement that like taking the stairs is important, that they maybe hear in the radio or see elsewhere, but in that moment where they're about to make that decision. And so this is a really lovely example where I think they turned the stairs into piano keys and made it more fun. And so they see other people going up the stairs and sort of making it more fun. So it's like an intervention sort of in the moment when they're about to do that. A more research-based example was a project that Gillian actually had worked on with parents of kids with ADHD and sort of parenting interventions to help them in the moment have interventions around helping them calm themselves down or well as their child. And so they had them wear stress monitors. And when they see that the levels are rising, they would deliver either through a mobile app or I think there's a screen in the in their home that they could kind of deliver these reminders of these techniques that they'd worked on. And it's really hard to get that right. So Laura, who became my postdoc after she worked with Gillian on this project, came was telling me stories about if you waited too late, the parents would get sort of like it was already too late, they're already overwhelmed. And the intervention was like, they want to throw the phone because they're already at this point where they're flooded. So it is sort of important to sort of get it before they're at that moment and sort of target these at the right time. And so there's some just techniques around sort of monitoring where people are and delivering the information at the right time. Gillian, anything else you want to add about that project since that was yours?
No, just that we've switched now, and it's now full on wearable focused, and now we monitor the kids and the parents and try to intervene with both of them, and it's a lot to try to predict who's going to throw their phone. But she's right, that is the big goal.
Yeah. Great. Okay, next up is supporting my supporters. And so thinking through this broader network of care. So I think a lot of you pointed this out in the techniques around engaging peers or engaging family members or other people in their community. And I think this is an important thing to focus on as well too. And so, lots of different ways you can do this. I think one of the things my work has looked at sort of thinking through, things from a family perspective and family informatics, as opposed to, so many of these health interventions assume that you're one person who lives alone, and especially I spent a lot of time in the sleep space, and so many of them assume that like you don't have kids in your house or pets or anything else. They assume that you sleep alone in a bed by yourself. But it's thinking through this broader ecosystem of the people that we live with and the people who care about us, and engaging them as best as you can. And so some great examples of some of the fitness apps will share. This has kind of become a little bit old school now, but they would share when you're about to go out for a run, and people could like your run. And I know one of the apps would actually, I use this for a little bit, would like cheer every time someone liked my post that I was on a run. I would hear it in my headphones to say like, yay, good job. And so kind of just encouraging people as you're out for a run. And Daniel Epstein did a really great study of like what kinds of social support on social media actually help people and engage people, and which kinds aren't. So it's a really great paper with a framework they did, that things like sharing details, just sharing generic auto-generated things to social media gets zero engagement from peers, and it's like seen as annoying, or like nobody cares about your run. But if you shared something about like, this is the first time I went running in 3 months, or this is the longest run I've ever had, or if you share some of those details, that's important. If you share a photo, like take a photo of your run and share it, then people are more likely to engage. It's a really lovely framework around what types of social sharing are most effective and seen as engaging for both the person that's using them as well as their support network. Gillian also reminded me of the website Caring Bridge for cancer support. And so you're kind of bringing together community people around a patient and finding ways to kind of just giving those comments or giving those hearts, or there's also concrete ways of offering support as well too. Bringing them meals, other sorts of things are sort of built in, and it's all about bringing together a community around someone and caring for them. Okay, next up is communicating my language. And so I know Gillian and I are both been working more towards community-based design. So this is kind of where a lot of this comes into play, of like really, really getting to know the communities that you're targeting with your interventions, and ideally designing an intervention along with them, bringing them into the process. You're working with them to think through like what's motivating for them, what's meaningful for them, and pulling together and using some of that into the design of the tool itself. And so, so one example here at the top, Gillian, this was which app was this one that you put in here? You want to talk about that one?
Froggy Body. It's an exercise game for autistic kids that we're doing in partnership with folks in Mexico. And this is run by Monica Tentori's lab down at CISESE. I know Vivek, you know Monica. So this is a Spanish-based language app. Here in Southern California, we do a lot of our work in Spanish and English. Side note, if anyone has any Vietnamese or Korean grad students that would like to work in this space and come be my postdoc, that would be amazing, because we'd like to do more than just Spanish and English, given our population here. But yeah, very the challenges of both the cultural competency required to make sure that it's not just the language, but when we say language, we mean broader than that, is super important.
Yeah, absolutely. Yeah. So the other, I think I mentioned the child developmental screening project, and I'm working with a collaborator, Kendra Lillenquist, who is bringing some of this community engagement piece too, and sort of thinking through, some of the developmental milestones that kids meet are really culturally, North American or in particular, white American, because that's kind of where a lot of it was based on, and sort of thinking through just, things like, one of the milestones is, does your child, respond or pat to in the reflection in the mirror? And, in some cultures, it's actually like considered not a good thing to allow your kids to tap themselves in a mirror. It's, there's, kind of concerns or cultural concerns around mirrors, other sorts of things. Being able to use a fork or spoon is a very, Western thing. And you have families who primarily eat with their hands or use chopsticks who don't use those things. It doesn't matter that they're using a fork or a spoon per se. It's all about kind of fine motor control. And so are there other sorts of milestones or things that can be engaging with these families that are relevant to their culture, that are not sort of, and so kind of going through and doing this cultural competency assessment of your materials is important. And one of my favorite examples is not one I worked on, but Andrea Grimes Parker, she's a professor at Georgia Tech as well too, and went to grad school with Gillian and me, but she's working on some really lovely community engaged health apps, particularly with Black Americans. So this is one where they're using around care around people using church groups. And so they were building in specifically characters that had been designed around people in their community, and chatbots and things around that were engaging them in the community using the things that they cared about, right? So sharing prayers with their families, you'll engage with their church groups, and really kind of focusing in on the culture that matters to them and building an intervention around that. So great. So that's sort of the list of examples. There's so many more. Gillian and I were sort of like, what do we, which ones do we leave out? What do we have time for? So we wanted to now do our first breakout room session. So I'm actually right on time, surprisingly. But we're going to spend about 10 minutes. We're going to open up breakout rooms, and you can join with your teams. And I want you to sort of take through some of these techniques, and you can bring open the slides. I'll put the link again if you need it. And think about some of these techniques or some of the other ones that people mentioned in the chat. And how can they be maybe integrated into the design of the interventions, the mHealth interventions you're thinking about for your projects? And so we're going to do about 10 minutes of breakout rooms. But before I do that, do we have a quick, I see there's some questions in the chat, but Gillian's been doing a good job of responding and taking care of it. Are there any kind of broader open questions before we do that? And we're on time now, but if I open up for questions, we'll see how we go. But
I did see the question about evaluation. Don't worry, there's a second.
Oh, good. Yeah.
This,
Okay.
This talk, but lots of great comments in the chat.
Great. All right. So I will see if I can find my buttons again, and they always disappear. Oh, they're there. Okay. So I think I have to stop sharing to do that. So basically, we are going to go into breakout rooms for about 10 minutes, and you're going to discuss sort of like of these techniques. So you have social sharing, cultural competency, mapping out where you are. Are there things that you maybe are in your interventions that you could add to it? Are you doing a good job of this already? So maybe spend about 10 minutes, and then we're going to take a break after that as well too. So we can stretch, go refill their coffee, and then come back for the second half where we'll talk about ethics and evaluation. So welcome back, everybody. Hopefully you had some good discussions around some of the ways you can maybe integrate some different techniques around engagement. And next, Gillian is going to talk through about how you get there. So Gillian, you're up.
So sorry. I have a child who's been throwing up all morning.
Oh, no.
And he's talking to me right now. The joys of,
I can do the slide if you need a minute.
Do the slide for me, please.
Okay.
I'll be back with you. Sorry.
Okay. It's a short slide, but hopefully it'll be okay. So thank you all for bearing with us. So how do you get to patient engagement? Well, we're in human computer interaction, human-centered design, and so we're really big fans of engaging people in the process of designing and with the communities you're working with. to understand, you do research with them before you design it, you generate lots of ideas, you prototype those ideas and you iterate, you put them in front of people, get feedback, and you iterate on them. And so I know Mark Newman did a lecture on human-centered design, so you can go back and kind of watch through and some of those techniques on kind of how you engage in this process of prototyping. But you brainstorm lots of ideas, engage with the people that you're working with. You could do focus groups with them early on, or interviews. Involve them really early in your process, and make things out on paper and show them to people, get their ideas, and sort of refine them as you go through them, evaluate, and then kind of work through and iterate over time. So human-centered design is how we usually try to figure out engagement, because as I mentioned in the beginning, different people are going to be, and different populations are going to be motivated by different things. So it's really important that you engage with them throughout. Okay, Gillian, you ready?
Yes, sorry, back now.
Okay, now we're going to talk about ethics.
We had it all covered, but then when my husband left to take the one to camp, the other anyway. Okay. So we're going to do another breakout room. We thought the middle of the session would be a good time to have some good discussion time. And so you're going to go back into your teams. And I kind of mentioned this a little bit in sort of the concept of conflict of commitment, where you might have interdisciplinary team members here, and some of them, and maybe you're working with a commercial company or commercial product or other kinds of things. And there may be just these different challenges of what comes up and so on, but also there may be even more nuanced things that are starting to come up. And I know I've certainly heard it in team 2, these kinds of discussions. So I'm guessing that they're happening in other teams as well. But what are the questions and concerns that arise for you as individuals and as groups around how you think about engaging with technology and where things can go wrong? So I know one of the design techniques that Julie uses a lot when she teaches undergrads that I just absolutely love is like thinking about what would an evil genius do with this particular thing. So what is the most evil response to this particular challenge? And that is a really fun way to be creative from a design standpoint, but also helps you kind of think about these unintended consequences and the ethical concerns that may arise. So what do you think about the notion that we may be using technology to manipulate patients, to manipulate their caregivers and other folks? Or where could this go wrong if for-profit companies get a hold of things with different sort of ethical standards than you might have, and so on? So we really want you to kind of dive into those questions, but also think about what can you do as scholars and researchers now to safeguard and address these concerns before it gets to that point. So really baking in the notion of thinking about the ethics of the technologies we build very, very early in the process, and what might you do. And don't worry about whether or not what you want to do is technically feasible, or if there's policies that already exist. You can say things like advocate for laws, advocate for policies, build this thing that's magical and doesn't exist yet. You can be very creative, but think about both the questions and concerns that arise for you, and then also how you want to address these in your projects. And we're going to also ask you to report these back in 1 minute or less with no slides. So we're not giving you very much time for discussion. So you're not getting very much time for report out either. Don't be fancy about the report.
I think we just had five minutes of discussion in your groups and 1 minute report back per team. So we're going to kind of get this done fairly quickly. So I'm going to open up the breakout rooms again. Okay. Team 5 is first. So 1 minute report back of what you discovered.
Great. So we kind of talked about 3 different buckets of concern. The first one being privacy, second one being unintended consequences related to our intervention, and the third kind of being access and equity as to who is able to participate in what we're thinking about. So in terms of privacy, important things that we talked about in limited time were to make sure that we worked with a solution that had kind of data privacy securities in place, and also that we made sure that what was private versus what was not was really clear in the consent forms in an accessible way. The second thing that we talked about was unintended consequences, and our intervention involves possibly a group chat between anxious children and their parents. So we talked about different ways that group chat could either be, actively monitored by a person, or using kind of things like regular expressions or natural language processing to determine when an alert needs to be sent to some type of clinician if there's a severe issue going on with the child, or if possibly there's potential areas of abuse. And then lastly, We talked about how our recruitment could impact, only getting participants that already have really good access to different mental health related solutions and interventions, and thinking through where are different places that we could recruit, other ways that we could offer the technology that will be needed to be involved in the study. So we make sure that we have kind of like an inclusive and equitable approach to how we're thinking about our project.
Awesome. Thanks, Nat and Team 5. I put kind of just your highlight in the chat so people can have that as well too. So, all right, random generator picked 4 next. So you're up.
So for Team 4, we mostly, I think, just focused on one central topic. So what we've been talking a lot about is social network, essentially interventions for older adults. And one concerns in our ideas, the app that we might use to prompt some of this, right? You're also collecting data on people who aren't your main participant, right? Just incidentally based on contacts and things like that. And so I guess that centers around privacy as well. And that's the main topic we talked about the entire time, so.
Oh, Team 2. Sorry, I was muted. Sorry, Team 2 is next.
Yeah.
I can summarize what we talked about. So we talked about privacy also, like if we're collecting certain information from people, how we sort of ensure that information doesn't get out. We've been talking about a physical activity intervention and sort of the ethical considerations in terms of encouraging more physical activity throughout the day, despite things that might counterindicate more physical activity. So, for example, walking around when there's excessive heat, which is something that many of us have been acutely experiencing recently, but also just if patients actually have medical problems that they didn't relay to us, but that aren't, it wouldn't really be a good idea for them to increase their physical activity, and sort of just that process of like, we're sort of probably in a digital intervention study really relying on their report. And so we can't really be as sure as we might like to be that this is a good idea for them. We talked about potentially getting people like hooked on meeting their step counts, and that being something that's like a sort of addictive process, or they're really ramping it up too fast. And then last, we talked a little bit about collecting any information on suicidal thoughts, and there are kind of 2 camps of thought. One was it's important not to collect that information, and so not to have like free form responses enabled, because then we'd sort of be liable for anything that would happen. And the other was that maybe that those thoughts are going on whether or not we collect them, and it's our obligation to collect that information, both for the scientific community, but also so that there's any opportunity to intervene, even if it can't be like instantaneous. So that's something that I think a lot about and I'm really interested in. So
Great. Thanks, Jessie and Team 2. Next up is Team 1.
Sure. So we talked about a couple different things. The first would be kind of the long-term implications of the project that we're doing. So, for example, we're looking at the balance between sleep and exercise and how that relates to cognitive functioning. And so the concern could be that in the future, could that kind of information be used by an insurance company, for example, to deny people coverage or to deny people care or disability or something like that? So are we kind of creating a system that then could be used against the people who we are working for? We also talked a little bit about incentivization within the study and how you can get participation while also balancing out that like, this may not be in people's like best interest at the time to be completing all these surveys and wearing a watch and things kind of like that. And then we also talked like other groups did about sort of unintended consequences of the project. So for example, adding a watch, are people going to be modifying their behavior because they're participating in the intervention? And then if we're doing a naturalistic study, is our data going to be reliable? And then kind of my concern, which I think relates to Team 2, is, I work in eating disorders, and putting a step counter on someone would probably not be a great idea. So thinking a little bit about who are we working with, and are we, again, kind of the unintended consequences of some of these physical activity types of interventions.
That's great. And I love that insurance companies became the evil, what would the most evil person you think of too with this?
I mean, it's not like they aren't. Okay.
I know. It totally makes sense. So.
Yeah, I just think we have to, with all digital technology, right? We have to think about, like, in a capitalist system, how can it be used to provide access or to deny access? And that's kind of the reality of
absolutely
how things get funded and paid for.
Absolutely. Thanks. Is it Kara or Kara? Kara. Yeah. Thank you.
Yeah.
And team 1. Thank you. All right. Last but not least, team 3.
I can volunteer for team 3. A lot of what we talked about has already been mentioned, but particularly 2 things stand out. One is unintended consequences. So our intervention, or at least the direction we're thinking about, is interventions for young adults with type 2 diabetes using advanced diabetes technology, particularly continuous glucose monitors. So one being unintended consequences, whether it be a user or patient receiving interventions and kind of swinging too far in the other direction, which could cause additional health issues. So that's one. And then the second one being access and equity, similar to what has been mentioned. Given that sometimes these technologies are more expensive and tend to be available to some populations, but not as accessible to some other populations. So we talked about that, and we also talked briefly about incentives, especially from a research perspective. There are lots of research studies that incentivize people for whether it be completing XYZ goal, but that could also have unintended consequences because sometimes people get motivated by the incentives as opposed to the actual goal itself.
Great, thank you so much. Yeah, the expense, especially some of these more advanced devices with hardware, or smartwatches and things like that. And they may be really innovative technically, but the access and equity issue is a huge issue for those. And so I think that's one thing to kind of really think through. And that's why we in some of our studies we always just went back to text messaging, right? It didn't. Nowadays, like pretty much most people have smartphones, and but not everybody has data plans, and not everybody has like large storage, and so some of these things become real concerns in terms of some of these advanced engagement techniques also become equity issues if they're effective. So thanks so much for that, team 3. All right, Gillian.
Fantastic. All right, so we've talked about how you can do these things. We've talked about why you may or may not want to do these things from an ethical standpoint. But now we're going to talk a little bit about how we're going to evaluate what's going on here. So first and most important reminder about the slide we had at the very beginning. You can't evaluate something if you don't have a good operational definition for what the heck it is you're evaluating. And so making sure, what do you really mean by engagement? Is it learning engagement? Is it health engagement? Is it engagement with the app, et cetera, is going to become really, really important before you start doing things. Then you can figure out your measures. I'm super measure agnostic, as is Julie, as are a lot of you, as I understand it. So that's great. Want to make sure that there are qualitative measures, there are quantitative measures, there are validated things out there, there are custom things that you might want to do, all kinds of different options available to you. There is no way in the 38 minutes that we have left today that we could go through all of your evaluation options. So just like we did with the design section of this, we're going to walk through some examples, but want to be really clear that there's just a ton of different ways to do this. And if you have clarity on what it is you're measuring, it will become much easier to go through all the options that you have. Okay, so I want to break this into sort of 2 parts, just as we did in the beginning. So there's a sort of health and wellness part of this, and then there's going to be an engagement and the tech part of this. So let's start with the sort of how do we measure engagement when you think about it in the health and wellness sense. This is one of the places where you're going to find some validated measures, the goals of which largely are about, can we figure out how engaged someone is? Can we predict how engaged they will be based on whatever's going on? And can we evaluate change over time, right? So for a lot of you, you want to change some outcome, or you want to change the level of engagement with their health or other kinds of things. So a lot of these tools are about being able to deploy them multiple times over the time period. I would say there's some debate in the field as to whether or not these things are truly sort of validated patient engagement measures or not. I'm not going to dive into those debates right now, but you can do some reading on sort of what people think and the sort of challenges and future directions that people see in this space with this couple of references here. And as before, if your institution doesn't have access to some of these references, just drop me an email and we can get those to you. But I want to walk through a few of these that are fairly well known, particularly because you're in the process of writing grants. And when you write grants, often a good sort of grantsmanship thing is to use some very well-known tools that already exist out there, or at least sort of admit you know about them and so on if you're making a different choice. So AHRQ has done a whole bunch of work, and I apologize, Google seems to be sort of downsampling these images in some weird way, so you may not actually even be able to read this one. But if you go to the ARC website, you can see the goal of the overall CAPS program. This is the Consumer Assessment of Health Care Providers and Systems. This is about measuring patients' experiences with healthcare. So how do I feel? How activated am I? How engaged am I with my healthcare system? This is, I would say, a fairly industry standard set of measurements and approaches because ARC is the ones pushing for them. So as you might imagine, they've been picked up quite a bit. I see them sort of just anecdotally becoming a little bit less popular, but that doesn't mean they're not still sort of, good validated industry measure things. This is really about ARC's long-standing commitment to improving healthcare quality through patient engagement and patient activation. So there's a whole bunch of stuff. And if you want to look systemically at what's happening and how your intervention might fit into a healthcare system, I think this is a pretty strong set of tools for using these kinds of things. They're almost all self-report survey instruments and those kinds of things. The one of these that I've actually used in my own research is this one, the PAM, the Patient Activation Measure. So that's not me advocating for it. It's just straightforward and simple, and that's why I've tended to use it. There's lots of reasons you might use something that's not just that it's straightforward and simple. But the notion here, it's a fairly lengthy instrument. It's a 100-point scale. So that's not, something you're going to do on a mobile phone quickly. But if you want to understand where someone's patient activation is as sort of a pre-post measure for some intervention, it can become useful. And what I personally have liked about this one is you can sort of see the scoring is they put you into these 4 levels. So this is a way that you might imagine if you believe an intervention is going to improve people's engagement with the healthcare system, over time, you could sort of predict we'd like them to move from a 2 to a 4, or we're only recruiting people who are already at a level 1. It's much harder to move someone from a level 3 to a 4, for example. Those kinds of things might be thoughts that you would go through in terms of thinking about your outcomes. The key here is they're sort of looking at how important does the person believe their own role is in their healthcare management? I find this comes up a lot with mHealth kind of interventions, right? So if I don't believe that I can make change, that I'm involved in some way, why am I going to pick up my mobile phone and do something with it? Having confidence and knowledge necessary. A lot of mHealth interventions are about increasing people's awareness of what's going on, increasing their knowledge, helping them map maybe some data they're collecting about themselves to what's known in the literature and so on. So it's sort of, you can see where that can fit in here. And then proactively taking action. This is one that I think is interesting in the mHealth space, right? Because a lot of what we're trying to do is scaffold that action. And so often the intervention is helping them take that action, and they may not truly be sort of proactive in it. So one of the things you might want to think about if you're using the PAM is how would you help them to understand a world in which they either don't need the mHealth tool anymore, or they're using it in a sort of different way and it's built in as a scaffold. I am not a person, by the way, who thinks we should get rid of all these tools. I always use a calendar as the example of an assistive technology or a health technology or any kind of technology that once you have it, it's never going away. Like I live by my Google Calendar. And so that doesn't mean that it's bad. A dependency on a tool isn't necessarily bad, but it's got to work into your workflow and so on. And you can think about the mHealth tools this way. And then finally, the staying the course, even under stress. And I would kind of broaden that beyond, they really are measuring sort of about stress, but I would broaden that to a larger set of like, as things come up, do you stay committed to the health thing? And that may involve continued use of an mHealth tool or not. So think about that. Oh, and great point. Julie about if the images are not great on your shared screen, grab them from the Google Doc directly. She's put the link back in the slide.
Yeah.
And Xiaoxing, great question about, do you use the score to differentiate the level? Yes. So the PAM scoring basically tells you what level they're in. So it gives you a bracket that they sit in. Okay, and then there's the broad notion of patient-reported outcome measures. I'm guessing a lot of you have used this in some way before, this sort of broad set of thinking about what is a patient-reported outcome. So what do we, and especially in the mental and behavioral health space, right, we heavily rely on patient-reported outcomes and so on. So do I have symptoms of depression anymore? Do I have symptoms of anxiety? Any of these different kinds of things. The National Quality Forum, I like their definition where they just say that patient-reported outcome measures are any report of the status of a patient's health condition that comes directly from the patient. And this is a space where we see mHealth being engaged a lot. So we're collecting data often on a daily or weekly basis direct from the patient about how they're feeling. And it's not interpreted through someone's notes in the EMR. It's really coming straight from them. And so when we think about fitting an mHealth intervention, for example, maybe into a broader program. So if it's a program to support families coping with ADHD or a program to support weight loss or whatever the case may be, putting the mHealth tool in there, one of the key things that the mHealth tools can do is collect the patient-reported outcome measures and feed those into the larger evaluation of how the health engagement is going. Okay, so that's sort of the health engagement piece of this. I actually suspect that there are people on this call who are much more informed about that side of the world than I am, because, you know, Julie and I work with clinicians and so on, but we are not ourselves in that space. What we also want to talk about is, what do we mean? How do we evaluate engagement in the information sense, in the design sense, in the human-computer interaction sense, which is more sort of in our wheelhouse and fits into some of the techniques we've been talking about. So I put some big questions here that are the kinds of questions you might ask yourself if you're trying to think about, have I built an engaging tool? Are people engaged? Is it usable? Is it enjoyable? Is it useful in some way? So there's loads of things, tools that we use on a regular basis. I'll use my calendar as an example again. I do not find it enjoyable to use my calendar, but it's incredibly useful and it's mostly usable. So these are not things, you don't have to have all of these things, but think about these as sort of categories of things. And then there's behavioral metrics that you can use. Are people actually using it? Are they adopting it in some way? Are they fitting it into their lives in ways that you didn't expect? Are they sort of adapting it, changing it, making it work in these other ways? Do they want it? Do they recommend it to others? Is it causing them any other challenges? So have we now inserted a thing into their life that's created undue burden in some other way that may be outweighing some of the benefits that it's having? So that's sort of the reverse piece of this. And would they keep using it if they weren't in a study? And this is one of the big questions that we often have about mHealth. I know my team that I've been working with has been talking about this a lot. Like, how do we know? How do we measure what's going on or what they might do if they weren't being compensated or enrolled or socially pressured or whatever else because they're in a research study? So let's talk about some of the ways you might answer these questions. And the reason I wanted to start with guiding questions is that the ways that I'm going to present to you that you might measure these may or may not work for what you're doing, but the guiding questions probably work for most of what you're doing, and you can think about what measures you might use. So one of the ways that we can think about engagement is, before you even talk to a single patient, before you put the tool out there at all, use design experts to think about, is this likely to be engaging? So we know a lot about what makes tech engaging in various ways. And so you can start with this. And if you're in a university that has a design department of some kind, or a human-computer interaction, or, you know, in my case, informatics, in Julie's case, human-centered design and engineering, our departments come under a bunch of different names, but go find these people. I know you have them within your team, so I'm not worried there, but moving on in your lives, and see, sometimes even just having students run through a basic discount evaluation method can help with a ton of things. So one of the most common ones that we teach our undergrads is called a heuristic evaluation. And they're basically going to walk through your interface and look for usability heuristics. I've put a particular setup here. This is one Schenken Barker from, 20 years ago. 20 usability heuristics. There's loads of them. In fact, Julie, I think, wrote a very good paper when she was like in grad school a million years ago about usability heuristics for information visualization techniques. There's, for whatever your thing is, there might actually be a paper that exists with custom heuristics, but these are some standard ones that you can use. And if you miss on this stuff, the likelihood is you're going to have a frustrating tool that people aren't going to want to use in some way or another. If they're going to get stuck on errors, if they're going to not be able to predict what the thing is going to do when they do something, if it's, you know, not going to be accommodating to the way that they live their lives and so on, you're going to have problems with engagement from the start. So you can do this before you've done anything with a patient. And I super recommend doing some of this kind of evaluation. I've put the link to the Nielsen Norman Group discount usability evaluations website. It's a sort of wonky, not great, ironically not super usable website, but they have links to papers and a bunch of different tools up there, and other kinds of things that you can kind of check out. There's some debate about the Nielsen Norman folks at the moment in our world. We won't dive into it. I just like to flag for you when there's debates about various things. Okay. There's also, here's another example of something that can help you sort of predict ahead of time if your tool is going to be engaging. So this is what Google uses, their HEART framework. I think we got the EAST acronym earlier, which is another good one, but happiness, engagement, adoption, retention, and task success. So you can start to look at these things and you'll see the signals that they use. Some of them require like launch of a full-on product. So returning users, do you ever subscription renewals? We've got a commercial product out there. Some of these things, task success and so on, this is about doing some usability studies ahead of time before you put it out for the clinical health piece. And so, you know, a lot of times I like to see built into like an R21 or so on, some notion of a sense of usability, even if it's a discount technique and these kinds of things. Okay, so let's talk about what these might be in some detail. So the HEART framework is a really good way to sort of think about them at a broad sense, and we can dive in a little bit. So you might do some studies in the lab or in some small studies before the launch. Good news, by the way, for those of you who are not computer scientists, you can publish studies with like 10 to 20 people in them in the HCI and design world. So this is not a waste for you junior faculty out there who are like, how am I going to get published with this little thing that's not an RCT? You can publish this stuff in the design space. So start looking at some of these things. You might look at task success rate. Where are they failing to finish whatever your intervention technique is? And then what's the rate of success? Do you have a standard level that you want them to succeed 95% of the time, whatever, but also then how and why are things breaking down? That helps you find places where you may have built things wrong and so on. Task completion time. So this could be things like average completion time, in which case we remove all the people who actually failed, or it could be how long does it take until they fail, right? Failing rather quickly on a task is much less frustrating than failing over an extended period of time. So you're going to want to kind of think about those kinds of things. And then what's their average time on task? How much are they spending in your app, whether they sort of fail or not? And I love, by the way, that people are using Julie's paper in her class. So you can check the chat there for that. But some measures do require a much bigger field study or the launch of a commercial product, right? So if we're thinking about conversion rate, you're probably going to need a fairly big N on that. So conversion rate for people who aren't used to that sort of terminology is how often did use of the tool lead to the desired effect? So if I'm building, if I work at Amazon, I want the desired effect to be that you bought the thing, whatever that thing is that I'm trying to sell you. If I'm trying to get you to walk more, I want the desired effect to be that your steps actually increase. So think about what is the conversion from the intervention to the effect that you want. And then there's a whole bunch of stuff about satisfaction. The tech world lives for satisfaction. This is how we increase customers. This is how you increase, the scale is sort of the big thing, right, in tech right now. So there's something very basic, the customer satisfaction score, people call this the CSAT. This is basically every time you interact with a website, you get something prompting you at the end, or anytime you take your car in to get serviced or whatever, you get the like, how'd you feel about that? Give me a 1 to 5, right? These are very basic things. They're super quick interactions, and you're trying to understand how satisfied are people with a particular interaction or experience they've had. Net Promoter Score, this is about how likely are they to recommend to someone else. You've probably been popped up surveys about this too. How likely are you to tell your friends that they should fly Delta? These are the kinds of questions that we're asking when we look for a Net Promoter Score. So it's not enough that I want to come back, but I'm going to tell my friends that they should do it too. I had a great experience with this weight loss program or this mental health program, and I want other people who might be struggling to do those things as well. And then there's things like customer effort scores. So how hard was it? If you want to be super formal about this, I like the NASA task load index. So NASA TLX is what people call this. So this is basically like, how hard was the thing you just did? And a series of questions about this. And NASA created this for all the obvious reasons that you might imagine when you're doing human factors work for launching spaceships. You really don't want there to be a lot of cognitive workload in engaging with that interface. And so if you're trying to build interfaces where you want to make sure that the task load is very, very low, then this can be a useful thing. It's a really intense thing, so you got to really mean it, that you want to measure their cognitive load. But if you're building, say, a tool for healthcare providers and you think that by using this tool, they might have to work less hard to be able to interact with their patients or something, it may be worth engaging with those kinds of things. Okay. This is the big one that I hear from a lot of clinicians and healthcare providers. It's just use, probably because it's really easy to measure. So it's very simple to say, did they use the tool at all? And it's also super important because, to Vivek's point when we very first started, if they never used the tool, maybe they got better, but it sure wasn't because of your tool. And if they didn't get better, well, you can't really blame yourselves either. So that's a sort of very basic one. But you might want to think about something more specific, like, did they use it every day? Did they use it weekly? Did they use it hourly? And that's going to really depend on your intervention, because maybe you have an intervention that you don't want them checking it hourly, that would be problematic, and that you really only want them in there every week or whatever the case may be. So thinking about use really in relation to your specific intervention, but also the retention. So if you think about, like, if we're building a social media company, we're building attention economy, and all we care about is that we retain your eyeballs for as long as humanly possible. And so then it becomes, how long is the session? I want it to be really long, and I want the time between sessions to be really short. With a healthcare intervention, you might have the reverse of that. I don't know, right? But thinking about what kind of retention measures do you want and do you expect from your intervention? And also, if prompted, how quickly do they respond? So if you, and again, it's going to be custom depending on your intervention. Maybe you have an intervention, the ADHD work that Julie was talking about earlier, we needed people to respond to that intervention quickly because we were trying to intervene to get them to, take 10 deep breaths before they scream at a kid. If that's your goal, you need a very quick response to a prompt. But it might be that your goal was to nudge them and to make them think about something, and you actually don't want them doing anything with it. So thinking about how quickly are they responding? Are you distracting them, or are you doing appropriate levels of attention depending on what your intervention is? And then finally, what do they do with the tool? So I know some of the teams have talked about things like, well, do they actually make it through all the steps, all the reflection steps of a particular intervention activity? Or do they read a lesson? Noom is really famous for this. If anyone's used that for health related things, they sort of coerce you into reading their health lessons with a lot of sort of gamification tools. So how do you get through that? Duolingo is another good example of this. They want you doing specific things. It's not enough to just be sitting in the Duolingo app. They want you working through the lessons. So thinking about what do you want to measure in terms of that? And the good and bad thing about computers is we can log anything. Anyone who's ever been handed a massive pile of logs and told to analyze them, though, knows that that's not always good. So if you can build on the front end, what do you actually want to log so that you can ask smart questions at the back end, it'll just save you a lot of pain. Okay, so we're gonna send you back to your breakout rooms. And
can I add one more thing real quick, Gillian?
Yeah.
I was just going to say one word of caution, given the massive amounts of data that these sort of measures can generate, is to be thoughtful about it and don't just collect everything for the sake of collecting everything because you can. You'd be really, think about what your research questions are and what your outcomes that you're really looking for, and choose things. Because I've seen studies designed where the intervention itself is like 5 minutes, but then there's like 40 minutes of data collection afterwards. And the data collection itself is actually more burdensome than the actual intervention. So just be thoughtful and not overdo it. You can definitely overdo it in terms of your data collection. So pick a couple metrics that you feel like are the most meaningful for you, as opposed to just doing everything under the kitchen sink.
Yeah, that is a great point. And also, even automated measures, you want to be careful because they're sucking up your battery life, they're sucking up your network bandwidth, all of those things. So
privacy concerns as well too, right? Yeah,
absolutely. Great point, Julie. Thank you. Okay, so back to your breakout rooms. And you can have, we're not going to make your report out this time because this is so custom to you all, but you can have about 10 minutes again to talk about, again, what does engagement mean in your projects? And so how will you measure it? Is it a health engagement thing? Is it an educational and learning engagement thing? Is it engagement with the tool? Is it all of these things? And we really want you to consider the whole spectrum of things, automated and self-reported, qualitative and quantitative, things that might be validated instruments out there, as well as custom tools that you feel like we really need to be custom thinking about this for our project. So yeah, back to your breakout rooms.
All right. Well, welcome back, everybody. I know that was really short. I want to make sure we gave you time because I learned that your breaks were quite short between sessions as well, too. So we want to make sure that you all had time. But if you want to kind of go back and chat afterwards, but we just want to make sure you had time to close the session. So we thought to make this even more interactive, rather than us taking away some takeaways, we thought we would generate them with you all. So in the chat, maybe if you can each put, this could generate a lot more, but what is one takeaway that you took away from the session that you think that you will use going forward? So maybe you take a minute or two to think about it and then share it in the chat, and we'll try to compile these and put them into the slides. Maybe you'll take like 3 or 4 slides with as many of you have, so we can have just kind of a nice summarized list of the takeaways from here.
And actually, I'm going to stop sharing because I just realized the slide just says, what are your takeaways? So
it does. Yeah.
Maybe not. You can, that way you can see each other while you think about your takeaways.
And it doesn't have to be groundbreaking. It can just be when I learned about a new tool. I like how the first 3 are all about, we all struggle to define engagement.
Yeah, language is really important. Yeah, I think this point about the ways in which we can accidentally modify the effects of the study with what we do is a great one. Thanks, Jeannie. And also just,
yeah,
I love all the people that are just like, this is really hard. Yes.
Usability is important. Yeah, you may have like the best, most effective and engaged, intervention that's based on really solid, good principles, but if it's not usable and people, it's a pain to use, then it's not going to be useful at all. How you design these things really does matter.
Mm-hmm.
Engagement value from both wellness and design aspects. Learning a bit, some more specifics about different types of it, like a heuristic evaluation. The 7 principles that we talked about. Yeah, the Johnson & Johnson one. That was actually relatively new for me. I was trying to find like a good framework to kind of go through all the examples that we had and organize them. And so that was a great one. Yep, not modifying the effect of the studies.
For there fun little techie things. Look how
you are already in the slides. So thank you, everyone.